Good afternoon. John Snyder here again for another edition of Newton-Wellesley Medical Group Lunch and Learn. Today on a beautiful Thursday, as our Thursdays turn out to be the last couple of weeks, we are really happy to welcome Dr. Avner Alifas back into the hot seat today, talking to us about sudden hearing loss. Next slide, please, Avner. We want to tease some upcoming talks coming our way. We have upcoming Lunch and Learns. By next week is school vacation week. We will not be here. Good time to see some of our old talks that are logged up on the intranet, as well as up on YouTube. And the following week, we'll be back with updates on breast cancer screening. And then following that, Kavita Sitharaman will give us another great talk on diabetes, about adrenal insufficiency in the primary care setting. So we've had some great talks upcoming in the first couple of weeks of March. Next slide, please. We wanted to make sure our folks know about our financial wellness series. Last night was the kickoff of the financial wellness. Next session will be a month away. We will be posting last night's session up on the intranet. For those of you who would like to watch it, it was a great talk about the blueprint for financial success. Please take advantage of that. And next week, there'll be 2 talks, 30 minutes each. And you can see the title there, Writing Out Market Events, Volatility, and How Do Taxes Fit Into Your Retirement Planning. So we're excited about this series. It's no cost, it's no rush. It is no hassle, and certainly a no sell, but definitely for you and your education, for financial planning, for you and your family. Please take advantage of it. And if people like it, we will continue it and keep going through. So please, next slide. We wanted to make sure everyone knew about our free Shipley Fitness Center. This has been starting since mid-January. It's going to go all the way to June 1st. And a special thank you out to Daniel Destin, the manager of Shipley Fitness Center. The Shipley office hours are 4:30 in the morning till 10 o'clock at night during the week, and on the weekends 5 a.m. to 6 p.m. So plenty of availability. And with your Newton-Wellesley ID, it is free. So please come on in and check out the Shipley Fitness Center. That might be something you want to incorporate into your life for wellness. And we want to make sure that you take advantage of at least one free session. Please come by anytime. We do ask that you fill out the health appraisal form that we can get to you before you start exercising. Once again, that's free. It starts at 4:30 in the morning all the way to 10 o'clock at night during the week. Next slide, please. And then lastly, we want to put a plug out for the Find a Doctor website. You guys all know that your patients are on the web looking for you and looking for other doctors, and it's important that we update your websites. If your photo looks like your wedding photo from 40 years ago, time to update it. Please, very simple to update it. All you need to do is send a professional high-resolution image to the email at nwhexperience@partners.org. But better, we have a professional photographer that comes on campus to take a great picture of you with professional lighting. And that has been occurring on a regular basis. We had a session maybe 2-3 weeks ago, and Bless has been coordinating that, and you can see her email there. Of course, if you want to update your clinical interests, you can email Audrey as well, of course, if there are any location or other changes. If you want to make changes to the website, you can fill out a request form. These are like other tickets you have filled out, except actually these get responded to pretty quickly. I have had put in a few updates already, and they are responded very fast. So if you have something that you see is wrong on the internet, we want to update it and fix it. Wrong address, wrong phone number, etc. So please keep us updated. Keep your photo updated. It's really important, as you know. So we want to make sure everyone is aware of all these. 2 other learning opportunities. Second Tuesday of every month, we have our APP Grand Rounds. Please make sure to check that out. If that's not on your calendar, you're welcome to email Amy Israelian or myself, and I will make sure that gets there. And of course, every Wednesday morning at 8:30, Dr. Larry Friedman puts on our medical grand rounds, and these are great talks. In fact, yesterday was an amazing talk on neuro-oncology. So please give that a try as well, 8:30 on Wednesday mornings. And with that, I will turn it over to Avner. Avner, thanks for coming here, and thanks for being here.
It's my pleasure. Can you guys, John, can you give me a thumbs up? You hear me okay?
Perfect. Sounds great.
Okay, good. So thanks everyone for joining. I'll try and keep you entertained. There's nothing I find more interesting than talking about the ear, and I'm sure that applies to each and every one of you. So thank you for joining. My office is up in the White Building, New England Ear, Nose, and Throat. My cell phone is here for all of you to write down. Always feel free to text or call at any point if you call me or text me, I don't answer, it's usually just because I'm with a patient, and I try not to interrupt while I'm with a patient. But leave a message or text, and I'll get back to you anytime. Our team, so I focus, I do general otolaryngology. I focus on the ear, and Dr. Glicksman is a general otolaryngologist, and he focuses on the sinuses and is fellowship trained in advanced sinus surgery. Johanna Lamb is our wonderful nurse practitioner who also sees all ear, nose, and throat problems, and we're lucky to have her spending a lot of time with our patients and also treating their TMJ with Botox injections. And Dr. Hayden is our wonderful director of audiology, and we're expanding both our office and our audiology team and adding extra booths. So they're always here to see your patients. And if a patient of yours needs an audiogram, but not necessarily seeing an ear, nose, and throat doctor, they can also just schedule a hearing test. So please write down my cell phone number, reach out if you need anything. Today, we're going to talk about sudden hearing loss. I notice I left out the word sudden sensory neural hearing loss, even though that's the one we all worry about the most. But whenever we have someone present with sudden hearing loss, there's actually a very long differential, longer than I usually think about, but it's always there in the background. And so it's a very important thing to remember. So the reason we always talk about sudden hearing loss as an emergency is because our treatment window for sudden sensory neural hearing loss is relatively short. We like to get it, the sooner you treat it, the better. If we can get someone in within a day or two for treatment from the onset of their symptoms, that's best. But even in this Harvard publishing disease and conditions here is trying to teach our patients, our population, that yes, you have to pay attention to it. You can't always assume that it's earwax or fluid, or make sure you see your doctor to make sure you get treated adequately. We're going to review some anatomy. We're going to review a broad differential for sudden hearing loss, and we're going to talk about some treatment options. So let's start with anatomy. And I'm not going to go into this in detail, but this is just here as a reminder that whenever someone has hearing loss, we think about, can you see my mouse there moving around? You think about the external ear and the middle ear causing conductive hearing loss, and you think about the inner ear nerve, cochlea and cochlear nerve, causing sensory neural hearing loss. So this is a normal eardrum. You guys probably don't have as nice images when you look at it every single day, but this is what they look like to me when we look at it with our microscope and our endoscope. It's actually a little bit clearer when we look under the microscope. This is a little fuzzy, but here we have a beautiful view of the malleus. We have a nice view of the incus right over here coming down, and the stapes is hiding in the background over here. And I'll show you even a better picture here of the right and the left ear. This is your left ear, this is your right ear. And you have a beautiful view of the malleus. A beautiful view of the malleus goes up into here, connects to the incus comes down. This is posterior superior quadrant of the eardrum, and you can see it connects to the stapes, and you can see this little line is the stapedius that attaches to the stapes. This is the cochlear promontory. The basilar turn of the cochlea is right over here, and here you have your round window niche. Your oval window is here, and here that dark shaded area, that's where the eustachian tube starts. Okay, so you can see a lot of stuff when you look through the eardrum. You just have to know where to look. And you can see this on the other side as well. This is the right ear, incus coming down. You can't see the stapes as well, but you can see this little shaded area, a little brighter line here. That's the chorda tympani right over here, the cochlear promontory and the round window niche. And here's the eustachian tube opening anteriorly. Okay, so this is another normal ear. I just wanted to remind you all that the vascular strip, a lot of the eardrum gets its vascularity from the superior portion of the ear canal here, and oftentimes you'll see these bright red lines coming down, and that's just normal. Okay, you can see here the eardrum looks normal. You have no fluid, no infection. That just is a normal ear exam. This is a nice view underneath. This is in a cadaver specimen. You're looking into the middle ear from the eustachian tube view. And here you have the malleus, you have your incus coming down, and your stapes is right over here. And this is your oval window over here, okay? And another little reminder here that when we look at the middle ear through the ear canal, we're looking at the mesotympanum. There's also this whole area up here called the epitympanum that's connected to the mastoid, and then down here is the hypotympanum. So we're looking at the mesotympanum in the middle ear when we look through the eardrum on our otoscopic exam. As a reminder, here we have the brain adjacent to the epitympanum and the middle fossa, middle cranial fossa. We have the facial nerve running through the middle ear. Sometimes it's not covered in bone in the middle ear, your chorda tympani, and you have your carotid artery nearby and the jugular bulb right over here. So there's a lot of important stuff surrounding. So when we examine the ear, it's important to look at the middle ear function with pneumatic otoscopy. I highly suggest whoever doesn't have a pneumatic otoscope, they're only a few bucks online. Buy a few because they always get lost or stolen, and then hook it up to your otoscope if you don't have that already. A tuning fork exam is critical when you're trying to differentiate between conductive and sensory neural hearing loss and you're not sure about your exam. And also, you can use the humming test, which has been sort of validated. I mean, there's this paper that looked at a small number of people that showed that the hum test is similar to using a tuning fork. And what you do is you have your patient hum, and you ask them, what side do you hear it on? If they're hearing it on the side that they have their hearing loss, it's probably a conductive hearing loss. Similar to when you put the tuning fork either on the forehead, I like to put it on the teeth as it vibrates directly into the skull. And if they hear it on the side of the hearing loss, that's a conductive hearing loss. If their hearing loss is on this side, but they hear the sound on this side, well, that's a sensory, probably a sensory neural hearing loss on the left side, okay? So, and just to again, a reminder to use the tuning fork as part of your exam. Also, check the face. Now let's talk about our differential. We're going to talk about a broad differential for sudden hearing loss. We're going to start with vascular. This is not common. Sure, stroke can cause hearing loss, but it's highly unlikely that hearing loss alone is what you get. In this study in 2009 in stroke, they divided up the presentations for the anterior inferior cerebellar artery infarcts, and just about every category that had hearing loss had vertigo and other symptoms. There was no category of hearing loss alone without vertigo. So that's unlikely that you would have a stroke just from a sudden hearing loss, at least not a large stroke. I mean, you could imagine that a tiny little stroke of the cochlea perhaps, but we don't know how to check for that anyway. So then we think about infectious and inflammatory. A sudden hearing loss with vertigo. And we think, and labyrinthitis is one of the first things that we'll think about. A sudden hearing loss after a recent URI and ear pain, acute otitis media. A sudden hearing loss after swimming, going to the beach, or sticking lots of Q-tips in your ears, probably an acute otitis externa, but there's obviously pain, drainage, itching, other symptoms that will clue you into that. Zoster is one that you always have to keep in the back of your mind, as people can present with acute pain and hearing loss before they get the rash. And if you suspect it, it's important to treat early on, just like anywhere else with zoster. There's certainly trauma. The history, again, is obvious. Usually happens when the 20-year-olds or 18-year-olds are car surfing and they fall back off of the car, hit the back of their head, they crack their skull base. Temporal bone fractures can cause, you can get a crack through the otic capsule, which is the hardest bone in your body within the petrous apex, if that brings you back to anatomy. You can have disruption of the acicula chain that suddenly causes hearing loss. You can have hemotympanum from trauma, and obviously an acute traumatic perforation, but the history is all usually there and obvious. Medications can cause hearing loss with gentamicin that we know of, cisplatin with the anti-neoplastic agents, and other toxins can cause hearing loss, but that's not something we see frequently. Autoimmune hearing loss. We see patients that present with recurring bilateral hearing loss responsive to steroids. Testing for that is not so helpful. There are case reports of people with sudden hearing loss associated with something such as Church-Strauss disease, but these are mostly case reports. It's not well defined in our literature, but we do see recurrent patients with recurrent bilateral hearing loss. Metabolic, there is an association with metabolic syndrome and a slight increased risk of sensory neural hearing loss. It's not necessarily surprising because even we know in diabetics, they get cranial neuropathies. We're more familiar with, I think, the third, I haven't seen one of those in a long time, third cranial nerve, but here we have eighth cranial nerve neuropathies, and suddenly they can happen slightly more common in metabolic syndrome. Iatrogenic, the one we worry about is antibiotics. Again, gentamicin and the anti-neoplastic agents can definitely cause hearing loss. There's some controversy, at least from what I see. I know we get patients sent to us for monitoring for hearing loss and chronic azithromycin use. But if you actually look, there are some case reports that suggest that there is hearing loss without, but I couldn't find a good study that showed a true correlation with chronic azithromycin use in hearing loss. There's definitely a bunch of studies that I list here that suggest that azithromycin is pretty darn safe for using and is not clearly associated with sensory neural hearing loss. So when it comes down to it, in the end, all the other things we listed on the differential, usually the history is really all you need to figure them out. The exam is helpful, but usually it's the history. The problem that we tend to face with idiopathic sudden sensory neural hearing loss is that sometimes it's hard to figure out if that's the problem, especially on the phone, or if there's earwax. So it's really important that, just using this slide to remind ourselves that if you see a patient with cerumen in the ear and a sudden hearing loss, please don't assume that it's the cerumen impaction until you've cleaned it, because you can have a severely impacted ear canal with cerumen. As long as there's a little insy-bincy place for the air to travel into the ear canal, you're going to get pretty normal transmission of sound into your eardrum and into your inner ear. So you have to clean the wax before you assume that it's a conductive earwax related hearing loss. Neoplasm, a small percent, around 3% of our sudden hearing losses that present have acoustic neuromas. And so we always get an MRI if possible, a CT if not, to rule out an acoustic neuroma as a cause of sudden sensory neural hearing loss. Now, I had to think for a second to put in a congenital one here, but there are congenital causes for sudden sensory neural hearing loss. The way the cochlea supplies, the body supplies the cochlea with its perilymph is through a duct called the vestibular aqueduct. And if that vestibular aqueduct, if you were born with an enlarged vestibular aqueduct, you can see it on the CT scan here. What happens is, what can happen is that with trauma or even without a clear reason, I guess you can have episodic and recurrent and progressive sensory neural hearing loss, and it could be bilateral, so that there can be congenital causes for sudden sensory neural hearing loss. So again, a reminder, this is the patient that calls you and says, I have a sudden hearing loss. They usually say to me, doc, I woke up this morning or I was in my shower, all of a sudden I couldn't hear anything. I was doing my work and boom, my ear suddenly went deaf. I developed ringing in the ear. in that same ear as the has hearing loss. The sounds sometimes are tinny. There's a metallic-like quality to the sound. Usually there's no complaint about vertigo unless it's labyrinthitis, because that's usually then the complaints are reversed. Usually it's vertigo that people are complaining, and they're like, oh yeah, and I can't hear out of my ear. Here, it's all about the ear, ringing, hearing loss, hissing sound, tinny sound, metallic sound. Yes, that can be from earwax. And so if you see someone with cerumen, again, just as a reminder, you got to clean it to make sure that it's not a sudden sensory neural hearing loss. So again, you examine their ears. If you're doing a virtual visit and they happen to have one of these endoscopes that are about $30 on Amazon, great. You can look at the eardrum and see if it looks normal. You can do the tuning fork exam. Remember, you can use the humming test, and then try and get an audiogram. With us, we promise we'll get you an audiogram. If for whatever reason, if our staff doesn't appreciate the severity, just please give us a page, send me a text, give me a call. We will get your patient in either for a hearing test or a quick evaluation. That's what we do. So there shouldn't be any resistance on our end to get them in quickly. But if for whatever reason we're not available, I don't know, we had a flood in our office and all the other otolaryngologists are on vacation, just treat them empirically. All right, so here's how patients present. We see audiograms with a one-sided severe hearing loss, decreased word recognition scores, and we treat them with oral steroids if they present within 2 weeks of symptoms. We give an option for steroid injections in the ear if it's within 2 to 6 weeks from the onset of their symptoms. And we use the steroids also so we use it for salvage therapy, or we use it for initial therapy if the patients have contraindications to oral steroids. We don't have other great treatment options. There's been a lot of things tried over the years. But given that this is a relatively rare event, and in many patients, the hearing improves on its own without intervention, it's very hard to now have studies. Oh, and that oral steroids are now standard of care. It's very hard to create studies that are going to give significant numbers these days. So we basically have oral steroids, injected steroids, and that's about it. And again, an MRI to check for an acoustic neuroma. Our treatment, once we've exhausted our steroid and giving the ear some time to recover, if it doesn't recover, you can use hearing aids if there's sufficient word recognition. And if not, a cochlear implant can be used with good results for a severe sudden sensory neural hearing loss. You can also use cross hearing aid devices. Basically, it means you send if this is the hearing loss ear on one side, you have a microphone on that side, and you send the signal to the other side and present it to the good ear. So at least you don't have to turn your head when you're talking to people on the bad side. So to make a long story short, sudden hearing loss has a long differential. The history is critical. Let's not confuse cerumen or a serous effusion with sudden sensory neural hearing loss, and that can be distinguished both with exam. The humming test, a tuning fork exam really makes a big difference. If you're not sure, please send them our way or start them empirically on high-dose steroids, and then give us a call anytime if you have any questions about sudden hearing loss or anything else that you might have. I have a few other slides. If there's time, I can go over a couple of other things, but why don't I take questions first since it's 12:55, and then I can try and answer any questions.
So if people want to throw any questions in the chat box, I just want to, that seems like a pretty high dose of steroids, 60 milligrams a day for 2 weeks, and then a brief taper. Is that validated, those numbers, or is that the Dr. Alifas recipe, or how does that work?
Yeah, so that's a really good question. And if you look at the guidelines, they don't specify. In Boston, if you look at what people do, all right, this is the recipe, right? So if you look at Dr. Rausch at Mass Eye and Ear, who probably sees the most sudden hearing, or Dr. Leah at Mass Eye and Ear, this is what they do. This is what I've been doing for the last 10 years. So this is not a validated number, but this is the standard of care in our neighborhood. It's a good question.
And then let me ask you one other question while we have you online then. And how does tinnitus fit into this differential? Would you expect to see it with acute hearing loss, or is it usually just a bystander from a nerve injury, or how does that work?
Yeah, it's a good question. So tinnitus in general, we think is associated with nerve injury and inappropriate signaling between the cochlea and the brainstem and cortex. So when there's a sudden hearing loss, we most often see tinnitus. Not always, but most often. So yes, we see tinnitus all the time, and that's something that should raise the concern level for a sudden sensory neural hearing loss.
Okay. And is that, a lot of patients like to make the distinction that it's not just a whistle, sometimes it's pulsatile. That doesn't make a difference here.
So pulsatile, I don't think pulsatile is something we usually see with a sudden sensory neural hearing loss, unless it's the sudden hearing loss is an acute otitis media or a cerumen impaction. It's usually more of a conductive loss that causes a pulsatile tinnitus in the acute setting. Chronic pulsatile tinnitus is a whole other lecture. The differential for that is very, very long, anywhere from hyperthyroidism and a valve problem in your heart to carotid stenosis, aneurysm, elevated intracranial hypertension, dural arteriovenous fistula, brain tumor, vascular loop in the internal auditory canal. I could go on and on for that. That's a whole lecture on its own. But pulsatile tinnitus is not usually associated with subjective idiopathic either hissing or ringing or cicadas, or that doesn't matter. Like the type, we listen to patients because they want to feel listened to, but I don't care if it's cicadas, I don't care if it's hissing, I don't care if it's a high whistle, I don't care if it's 6 or 8 kilohertz.
Doesn't matter.
Doesn't matter.
And they have all different kinds of explanations, that's for sure. Maybe we'll bring you back for another talk on that. I have a question here about, it looks like a little case. A patient with a cochlear implant on one ear and a hearing aid in the other feels the same results about hearing on both sides, wishes she didn't do the cochlear. Is that a common thing you see, or is it, they have different indications, one versus the other?
So that is a very patient-specific question. Usually the indication for cochlear implant is that they have tried hearing aids and they don't work for the patient. And usually so I don't do cochlear implants, just as a side note. So I don't have a big population of patients that I can go to with personal experience and answer from that method, but I can tell you the way we refer patients for cochlear implant is if they failed hearing aid use. They're not communicating, they're really struggling. So the idea there is to do better than the hearing aids. Now, if that one patient didn't do better, that's probably that's probably an outlier. Usually people will have a better result. And remember that patients are comparing one ear to the other, and that ear might be different than this ear, right? They chose the right ear for the cochlear implant because it's worse than the left ear, right? So if it was worse than the left ear and now it's just like the left ear with a hearing aid, well, that actually might be a better result. So I don't, but in general, it does better than the hearing aid because of the way we choose them.
Right.
And then also it's interesting, you can do hybrid models where you partially implant only into the high frequencies and then you do a standard hearing aid on top of that. So it's both a hearing aid and a cochlear implant.
And I guess the last question I'll leave this group with is there any red flag that we should see in the office that we'd be worried about, or a certain age group with sudden hearing loss that, you mentioned stroke, which sounds very rare. We're always worried about the red flag that we got to get you on the phone right away, pull you out of a room kind of thing. Is there any kind of red flag you would see with this sudden hearing loss besides getting folks on steroids as soon as possible? It doesn't seem like anything.
The only red, I guess the only red flag issue that I presented is stroke. Everything else I mean, even sudden hearing loss, even sudden idiopathic sudden sensory neural hearing loss, which you want to treat urgently, is not the kind of thing where you pull anyone out of a room for, right? Because it's just you want to get started ASAP within a day or two as fast as you can, but it's not, you know, send them to the emergency room type thing. So the red flags for stroke would be obviously you know the risk factors for stroke better than I do, and then vertigo and nystagmus. And then if you have nystagmus, then you can do the HINTS test. I'm not going to go into that, but you can do the head impulse nystagmus test, and you can see if it's central or peripheral, and you can decide whether it's labyrinthitis or stroke. But you know, this is the kind of thing where if you're not sure, you send them to the emergency room, right?
Sure.
But if it's not vertigo and you don't think it's labyrinthitis and it's just hearing loss, the red flag is a normal ear exam.
Okay. And then starting folks on steroids and sending them your way, would you prefer we hold on the steroids or starting them and,
no,
you know?
No, I mean, if we can get them in same day or next day, then you don't have to start the steroids. But if
Friday afternoon, 4 p.m.
If it's a Friday at 6 p.m. and our audiologist is out of the office and I don't know, and I'm away and for whatever reason, you know, just treat them.
Well, thanks very much. Thanks everyone for coming. And remember, next week we will not be here, but we're back the following week, and we'll have Dr. Alifas maybe back later on in the year to talk to us about pulsatile tinnitus. Thanks, Avner, for being here. Really appreciate it. Have a great one.
Anytime. Thank you for having me.
Okay. You're very welcome. Bye.